much for giving me the opportunity to talk about an institution I think that has touched most people's lives here and will continue to. And I think it's, I've always wanted to talk about it, I think, ever since 2010, so it's been quite a while. And things have moved on, things have got more interesting. And bear with me, there's a lot of information, there's a lot of charts. I've tried to keep it to charts and pictures, and hopefully we'll, because it's quite a complicated subject, and I've kept out a lot. So hopefully it'll come up in the questions and answers, but seriously, this is as concise as I can make it, hopefully. First slide, Amar. Okay, so if you cast your minds back to I think it was the opening ceremony of the Olympics, the NHS featured quite prominently. And it's quite something in itself. I don't think any country in the world would feature its health system in a sporting event. I think it's quite mad, actually, quite insane. But again, it reflects, I think, the population's view of an institution such as the NHS. And it's quite a unique view, because even if you look at the polls, and they poll all the time, the NHS always comes on top in terms of what represents sort of British values, and even more so, its support has never actually wavered in the sort of, well, how long now? It's nearly, coming up to 70 years of its existence. And what's interesting, I think in the chart there, that talks about how important is it to you to personally that free healthcare should be available to all, right? So they ask people, should free healthcare be available to all in this country? Overwhelmingly, I think nearly 80% of people said yes. What's interesting with that is it contrasts quite a lot with, for example, if you had the question of should benefits be available to all in this country, you get quite a different answer. But when it comes to the NHS, everyone is happy for it to be free at the point of delivery to everyone, regardless of background, regardless of what they do for a living, etc., etc. So the NHS, the commitment, the love, I guess, for the NHS has never wavered over the last few decades since its inception. And so it's quite interesting that the NHS is in crisis at the moment because of this unwavering support. You'd expect it to be doing quite well, but actually it's not. And I'll show you in a set of slides what's really causing this. So if you go into the next slide, and again, this slide is quite busy. I wanted to concentrate on three things, and then other things started coming up. So I had to put them all in, but I won't cover them all in the next half hour, but I'll just quickly skim over them. The big issue facing the NHS, I think, boils down to a couple of things. One is demographics. Okay, so we've got an aging population. Everyone knows we've got an aging population. Why is it important? I'll explain in a short while. We're also seeing a very different pattern of disease from when the NHS was first started. So again, that's quite an important cause. Workforce. I think the WHO estimates there's a deficit of 30 million health professionals in the world itself. So if you imagine NHS trying to compete for health professionals, if there's a worldwide deficit of 30 million, then it's going to struggle to actually attract the right sort of workforce to this country. And there's also obviously other political issues such as Brexit that's going to make it even harder to attract the right sort of health professionals to this country. And then there's obviously the, I guess, the political economic situation of the last few years, austerity and the financial pressures the NHS are facing. And lastly, throughout its history, the NHS has always been reorganized, and politicians keep on meddling with the NHS. Now, all this meddling is not, I don't think I don't think there's a malign intent behind it, but it also disrupts a lot of the delivery of healthcare in this country. And again, I'll show you exactly how. So if we move on to the next slide. Okay, so you've seen pictures like this. I took this from the BBC website because it's quite a nice chart and simple chart. Essentially what it says is the proportion of people over the age of 65 is going to increase quite significantly over the next decade, 2 decades or so. Why is that important? If you just click on. If you look at people over the age of 65 and people over the age of 85, they cost the NHS magnitudes more than someone under the age of 65. Now, it's a bit more complicated than that. The relationship is actually more to do with proximity to death. And again, it's something I'd love to cover, but we'll maybe cover another time. It's, again, our relationship with death is not very straightforward. And so we spend a lot of money at the sort of almost end weeks or end days of someone's life, mostly in vain, and that creates so much burden on the NHS. And it's the proximity to death that causes such a spike in the cost rather than the age itself. And there's a theory now that says actually, if you've got a very healthy population, a lot of that cost goes away. And again, I'll show you why. If you go on to the next slide. Now, this is quite a complicated slide. I was thinking of whether I should include it or not, but it's quite a neat slide because it shows you as you age. So we've got age at the bottom of the chart, and then you've got the percentage running up the other axis. And then if you can look at the lines, what it tells you is if you start from age 0 to 4, that really light color says you have no long-term conditions or no disorders. As you age, you start picking up disorders and diseases, long-term or chronic diseases, for example. So, for example, by the age of 65, half of the population have about 3 or more chronic diseases. And as you see, as you age even further, if you get to sort of the age of 85, if you ever get there, then half the population of 85-year-olds have probably about 4 chronic diseases. That's a lot. And these are diseases, each disease has got its own sort of medication. You're going to have to go to the hospital, see a specialist, you go to your GP, you have admissions into hospital. So imagine if you have 4 or 5 diseases, how much activity you as an individual will create for the NHS. So as the population ages, you can see it's a multiplier effect. And so the demand for healthcare doesn't rise with the population growth, it goes many times that, because we're not just growing as a population, we're aging. We're also not a very healthy population, so then we're more likely to get those diseases, and a lot of them are preventable. For example, diabetes, a lot of the cardiovascular disorders, etc., are preventable, but at the moment, as you age, the risk of collecting these diseases increase. Go to the next slide. And so the number of diseases we probably face increases, but also the types of diseases we are seeing in the modern age, I guess, what I call sort of mid to the end of the last century and this century, are very different to the ones that, again, the NHS faced when it first was established. Obesity is a big issue, and I'm sure you're well aware of the issues of obesity. It leads to cardiovascular conditions, diabetes, osteoarthritis, lots of other conditions, again, that create huge burden on the NHS. Up till now, the public health system, the NHS, has singularly failed in tackling obesity. And the reason why is it's intrinsically linked to the way our society functions and the way our economy functions. So, for example, if you wanted to put a tax on sugar, let's say, what do you get? You get immediate resistance from big corporations who are obviously dependent on selling sugar to us to make a profit. So our capitalist system does not allow us to I think, put in the right sort of interventions at a population level. Furthermore, if you really wanted to reduce obesity, you'd probably implement rationing. You'd probably restrict the amount of, for example, sugar and fat in people's diets. Again, what's the issue with that? We live in a liberal society. You cannot curtail the freedoms of people. Therefore, we are almost hamstrung. So we know obesity is a problem, but we can't do anything about it. We can speak to people, we can educate them, and we can explain to them why drinking fizzy drinks or eating chocolate or whatever it is bad for you, but actually we are quite powerless to stop it. And it's a big issue, and we have made no progress on it over the last few decades. I mean, little or no progress on obesity. And in similar ways, and I can give talks on all the rest of them, but in similar ways, mental health, our society actually breeds a lot of our mental illness. If you look at the isolation, if you look at the stresses, if you look at the social inequalities in our society, again, quite a liberal capitalist society, I think, breeds a lot of mental illness, particularly anxiety and depression. And if you look at the prevalence and incidence of anxiety and depression over the last century and this century, again, that's just risen, and we have made no impact on its rise. Cancer, by virtue of the fact that we are living longer, cancer is almost inevitable. And so we're obviously seeing increased rates of cancer. And again, as we age, diseases such as dementia have become more and more important. So we'll move on, but again, we can talk about this a bit further. But as you can see, we've got an aging population, and we've got these diseases of, I guess, modernity, as you might call them, and they are each creating their own burden on the National Health Service. Okay, we don't have to read this slide, but essentially, so you've got diseases and you've got the aging population. What you also have is the health system. Now, the health system started in 1948, a single-payer system, so the government essentially collects all the money through taxation and provides healthcare free at the point of delivery to its population. Every 10 years since its inception, there's been a big reorganization. Now, it's always been driven by either concern about the quality of the NHS or the quality of the services, or a concern about how efficient the health service is. But throughout its history, it has had every decade, it's had one big reorganization. Now, I'm not going to go into their detail again, but let me just say the last reorganization was probably one of the worst, most expensive and disruptive in its history by far. And we're still feeling the effects of it. Another aspect that's quite a feature of the NHS is the concern about how we pay for it. And there's always been a push to ration the NHS. So very early on, things like pharmacy, so paying for your prescriptions, dentistry, sort of optometry, was taken out of the NHS. Initially it was for free, but now we pay for, or at least co-pay for a certain amount of prescriptions, dental care, etc. Another way the NHS uses to reduce its spending is to make people wait for their treatment. So you increase your waiting lists and you push your costs down because you're pushing the cost to a future date. Another way is obviously operating on sort of price thresholds. So the National Institute of Clinical Excellence, when it judges a new drug, we'll see if it's cost effective. If it's not cost effective, it won't make it available on the NHS, and that's another way of containing the cost. And then there's unfunded activity. There's things that the NHS refuses to fund. Now, another important aspect of the history of the NHS is the rise of market thinking. So in the late 80s, early 90s, the idea was the NHS is inefficient, therefore we should try to make it more like the private sector, or actually implement a market within the health sector. So what they did was the biggest thing they did initially was to split the provider from the purchaser. Now, this might sound bizarre, but the NHS operated as one organisation in the past. So the Department of Health would give money to the hospitals or would give money directly to the general practices, and they would deliver care. What happened in the 90s was they split that. So there were organisations that would buy health services from hospitals and GPs. And the reason they thought that was going to make a difference was those other organisations, the commissioners, would hold the providers to account. So, for example, if you were going to set up a cardiology service, the commissioner would say, I want to set up a cardiology service in X area, in Harrow, for example. I want the cardiology service to treat, let's say, acute heart attacks, and we want services to look after heart failure, etc., etc. They would negotiate with the provider and provide and buy services off that hospital, for example. So what happened was, rather than being one organisation, it now split the NHS essentially in two or three. So the Department of Health, then you had a commissioner, and then you had a provider, whereas before it was just one NHS. What they also thought with this was, if you got that split, then any provider can provide that health service. So a commissioner doesn't have to go to one hospital. It can ask another hospital to take their patients. One of the big issues with healthcare is there aren't that many other providers about. So the problem with a lot of this market reform was healthcare does not operate like a market. Because the cost of, or the barrier of entry is too high, so you can't actually build a hospital very easily and decide to provide healthcare just on your own. You need a lot of capital. You need a lot of capital and expertise behind you. And so, and B, I won't go on to why the healthcare is not a market. Again, we can go through it in the question and answers. What Tony Blair did in the 90s as well was he got the private sector in to pay for a lot of the NHS infrastructure, private finance initiatives. So this was an easy way to get money into the NHS to build hospitals. Problem with this was its payback was extortionate. So we're still paying for a lot of the hospitals that could have been bought through government borrowing, to be honest, a lot quicker and a lot cheaper. But now it's here to stay. We're locked into private finance initiatives for the next couple of decades. So we'll see how that goes. But it's costing the NHS quite a lot of money. Tony Blair also, and the reforms under the Labour government, also brought in independent treatment centres. These are private clinics that are taking NHS activity. So it's free at the point of delivery, but private sector companies are actually doing the work. Most of it's surgical or orthopedic sort of simple operations, but still it was a big change in the way the NHS operates. Up till then it was just publicly funded. And then lastly, in the last set of reforms, the NHS is now being forced to tender out all of its services to any qualified provider. So it can't, in the past, they could prefer NHS hospitals, for example, and say, we've got a long-standing partnership with X hospital, we're going to give them the services to run for us. Now they are legally not allowed to do that. They have to open up the tender to anyone in the market. So any private or, let's say, voluntary sector provider can come in and bid for the service, and they can, in a competitive tender, and they can win it. Okay, so that's where we are up till now. So we've got a sort of fragmented system that has been meddled with for quite a number of years, but as I said, the last reorganisation has been the most disastrous up to date. So if we move on. So this is a chart, see, no more, hopefully no more text, but this is a chart about spending increases per year for the NHS over the last few decades. Now, the NHS is different to a lot of other sectors in a sense that you have to fund it above inflation for it to stay the same. A, because of the aging population. B, because of the increasing demand. C, because technology in the NHS works differently to technology anywhere else in other sectors. So, for example, if you invent a new drug, and it's a great drug, and it's going to cure a disease, in any other sector, if you invent something that's going to make your service more efficient or better, so if you're going to make your service better, it normally makes your service more efficient. In the health sector, what happens is you deploy this wonder drug. What happens? A, the wonder drug is expensive, and so pushes up prices and pushes up the cost of care. But B, which might sound harsh, but you're actually keeping the patient alive. You're keeping this person alive. And what's going to happen if this person's alive? He'll age and get another condition. And so you're stuck, right? So you keep these people alive, and then they get more conditions, and they come back, and they come back, and they come back. So it's almost shooting yourself in the foot trying to save the population. And it's an interesting way of putting it, but in the cold heart of day, that's what's happening. So anytime any technology comes into the NHS, it does not make it more efficient. There are big changes that have made the NHS more efficient and health services more efficient, but on the whole, the incremental technological change does not. It actually makes it worse. So the point is, you have to fund the NHS above inflation. So the average over the last few decades is 4.1% per year increase. So if you look at governments up to the sort of 1970s, they did go above 4.1%. And then we had the Conservative government in the 70s, and that dropped. But then we had the Labour government in the 90s, and that is, you can see the funding went up quite significantly. And look where it is now. And we ask why the NHS is in crisis. So this, on its own tells you a lot about what's going on at the moment. So if we carry on. Now this is another chart which is quite interesting. Again, this is spend as a percentage of GDP, so as a percentage of the income the country generates. So England or the UK has lagged behind the civilized world. So OECD is a sort of top 25, maybe more, I think they're 30 now, countries of the world. And their spending as a percentage of their GDP is a lot higher than the UK's. It's always been a lot higher than the UK's. And over time, so it started off with a gap of around, when Tony Blair took over, a gap of around 3%. And despite all the investment, we still, at the end of his, sort of under the Labour government, we closed the gap by 0.5%, all right? And this was through massive investment. And the problem is, and again, this is why this graph is interesting, is all the rest of the world increased their spending at the same time, right? So this is not just a UK thing. All across the world, health spending is going up as a percentage of GDP. And we've managed to close the gap, and then the financial crisis hit, and the Conservative government came in, and look, the gap's widened again. So it's another feature of the NHS. We close the gap, but we still have to fund. If you just click on the next picture. So this is just a point I'm going to make, is you put more money in, things get better. So here is a picture of waiting lists in the NHS over those years. So if you look at years in the 90s, and as Tony Blair took over and the investment, and the Labour government took over and the investment started flowing into the NHS, you see the waiting lists all gradually drop. If you click on the next picture. And surprise, surprise, the satisfaction in the NHS started to pick up immediately after that. Okay, so it's not rocket science. They put some more money in. It wasn't just the money. There were reforms, and there were targets, and there were quality standards, and there was lots of things that happened in the 90s that I think we should be grateful for. But it's a simple, almost too simple a relationship to look at how consistent funding can help the NHS deliver the care that we need. Okay, so that's funding. What also has happened, so the gaps increased because of the lack of funding that we're seeing at the moment in the last few years. What's also happened, if you move on, is social care spending has dropped. So again, if you look at this graph, it's a graph of social spending by local authorities. And if you look at from between 2009 and now, the actual drop, so it's the grey bars, have dropped quite significantly. Now the green bars is the money the NHS actually gave social care because they needed social care to help them out. And social care and healthcare are so interlinked, right? So a lot of the problems what you see now in hospital, and I think a lot of doctors in the audience can probably corroborate that, is the fact that the social care spending drop has caused a lot of reduced capacity in the community for things like residential care homes. Therefore, they are stuck in hospital, and therefore they are blocking beds, and therefore a lot of the pressures in the NHS can be contributed to some of this. But so not just the fact that NHS funding has gone down, social care spending has gone down as well. So it's almost like a sort of double effect on the NHS. And if you carry on, and again, we're not talking about it being static. We don't need funding to be just static. It needs to grow. Again, if you look at this chart, this is social care need versus social care projected spend. Look at that gap. As a population, again, we're aging. We need to spend a lot more on social care. We are going nowhere near that from a spend point of view. So things are probably only going to get worse, unfortunately. Move on. Okay, so we talked about spending, we talked about disease, we talked about the population aging. and I was talking about the reforms. So let me explain what the reforms did. So in 1948, the NHS was actually quite simple. It had the Department of Health, and you had hospitals, and you had general practices, and then you had local authorities who did other health services. What we got in 2010 was a fragmentation, total fragmentation. So look at the number of organisations in the NHS at the moment. And those are not the number, these are representations. So each of these boxes, for example, clinical commissioning groups, there's about 200 odd in the UK. Local authorities, again, a couple of hundred. Independent GP practices, about 7,000. The reforms didn't fragment it. GP practices were independent before the reforms, but what I'm trying to say is the NHS has become so fragmented that you can't actually deliver any consistent care anywhere. So the problem is a patient doesn't split essentially between a hospital, a general practice, local authority, etc., etc. It's he or she is one person. Problem is you have got 3 or 4 different organisations looking after his or her care. They do not coordinate, and it's extremely difficult to get different separate organisations to coordinate with each other. It's extremely difficult. And so what the Social Care Act did, Health and Social Care Act did was make a bad situation worse. Another issue of fragmentation is if you're going to make any change to healthcare, you need to be in charge of a population that's big enough that you can actually make the reforms that you would like. So the CCGs at the moment are far too small to make the sort of transformation the NHS requires. And so I'll cut this short because I know it's getting boring. So essentially, just think about the reforms fragmenting the NHS and causing chaos, all right? So if you go to the next slide. So it's looking pretty bad. It's looking pretty bad. So you might ask yourself, how is the NHS comparing itself to other systems? Now this is contentious because although I love the NHS, I don't think it's that exceptional, and I'll explain why. But here's a Bloomberg study from about I think 5 years ago, and it essentially picked out. Oh, okay, wrong slide. Sorry. But anyways, funding gap 30 billion. Move on. It's not that interesting. So this is the one I was talking about, sorry. So the Bloomberg study rated the NHS as 10th most efficient in the world, which is pretty good, actually, to be honest. But it's a very crude measure. What they did was they plotted, again, spend by GDP versus life expectancy. Now, life expectancy is dependent on a lot more than healthcare, let me tell you that. So I don't think it's a very accurate study, but on the whole, hey, it's 10th most efficient. I'm not going to argue too much with that. If you can see, the United States is always the outlier. It spends so much more on healthcare, and it's nowhere near the rest of the world. And that's just something to bear in mind. And it's never going to be there. Even Obama's reforms are never going to get it back there because it's just the way the health system is unfortunately designed over there. So, carry on. So there are other studies that have suggested that the UK is almost top in the world in terms of the health service. Now, the way they measure success or the way they measure excellence is a number of factors. So there's outcomes, how healthy patients become from going through the health system. But there's other things like access. So how easy is it to access your doctor? Do you have to pay to access healthcare? Things like that. So there's a whole host of sort of indicators, and they put them together and they decide how good countries' health systems are. The Commonwealth Funds, I think, is quite biased towards the NHS in the UK, and so they constantly get the UK up first or second. Interestingly, an OECD study suggested that the UK was actually below average in terms of its performance. And then another European agency suggested it was sort of middle average. And I don't question that, to be honest, because we do very badly in cancer outcomes compared to our European counterparts. We don't do very well in terms of life expectancy. European countries and other countries are better than ours. And we've got an issue with waiting times. But I think it's more of a reflection of our NHS or the system that we decide, that the NHS the way the NHS is designed, essentially. But we are leading in some respects in terms of cardiovascular disease and cardiovascular mortality, some of the diabetes outcomes. But more importantly, and I think this is really important, and I think that, again, this goes back to, I think, why people love the NHS so much. It's consistently the best healthcare system in the world with regards to equity and access, equity rather than access. So equity is, essentially, it's got its doors open to anyone and everyone. Problem with insurance-based systems, which a lot of European countries have, is no matter how well you design it, it tends to exclude a certain part of the population, either because they don't work, or they're not registered, or their circumstances are such that they just don't have an insurance card, for example. And so they find it difficult to deal with populations that are on the edge or marginalised. Whereas the NHS, no matter how marginalised you are, you can turn up to the hospital and get the best care there is, regardless. No questions asked. And I think that probably puts it apart from probably most healthcare systems in the world. I don't think there's another healthcare system like it. And I think that's definitely what it leads the world in. So if we carry on, so we talked a lot about the NHS and the problems and where it's going. So in 2010, when the Health and Social Care Act first was mentioned, the first thought I had in my head was, the NHS is getting privatised, definitely getting privatised. It was a culmination in a series of steps by successive governments. And again, it started with the Conservative government in the late 80s, early 90s, continued by the Labour government through the 90s, and then we had the Health and Social Care Act in 2010. I used to prescribe to this narrative, so I'll explain it to you. So we had the purchaser-provider split, right? The NHS split into purchaser and provider, made it a lot easier to privatise. You had foundation hospitals. So hospitals before were actually quite controlled centrally through the NHS and through sort of PCTs, etc. What, again, the Labour reforms did was they made them independent. So they could, some hospitals were made independent so they could actually look after their own budgets. Making them independent is almost another step towards privatising them. You know, if they are independent, it's almost a step further along the line. And now when the Conservative government took over in 2010, whatever it was, they made it mandatory for all hospitals to become foundation hospitals. And then there was this law about any qualified provider. So the NHS commissioners are forced to tender out their services to any provider. So I thought, actually, if you put all these things together, it's not far off. It's not a lot of steps that are required to actually privatise the whole thing. Now, we can talk about whether privatisation is actually good or bad. It doesn't really matter who delivers your care as long as it's free at the point of delivery, but I can pick that up in the question and answers. But at the moment, just whereas private sector was minuscule in the NHS, now £1 out of every £8 spent in the NHS money goes to private sector. So that's a massive change to what we were about even 10 years ago, to be honest. So the private sector's in, whether we like it or not. Whether the NHS is privatising, I'm not so sure. The reason I'm not so sure is in the last few years, a policy document came out from the NHS called the 5-year forward view. It talked about reversing a lot of the fragmentation. It talked about collaboration, and it talked about accountability to a population. Now, it's a total reversal of where I thought the NHS was heading. So it's given me a bit of a second thought about, actually, I'm not quite sure where it's going now. I thought there was one sort of direction, but I'm sort of having second thoughts. Now, I'm going to talk about 5-year forward view and the sustainability and transformation plans in a second. Actually, let's move on to that. If we're going to move on to the next slide. We're nearly done. So what the 5-year forward view says is the NHS is fragmented. We're in crisis. We need to start working together in a better way. So each area of the UK So general practices, hospitals, local authorities, providers, pharmacies, etc., etc. Everyone is going to have to collaborate to plan more effectively. And furthermore, those providers and commissioners are going to be held to account for the way, how healthy their population are. So instead of the GP being accountable just for what they do, and the hospitals being accountable for what they do, and let's say local authorities or pharmacies being accountable for what they do, all of them are going to be accountable for the same thing. So there's no passing the buck anymore. They're going to have to pool their resources and plan collaboratively. Sounds amazing, doesn't it? There's a problem. The NHS is going to have to save 22 billion over the next sort of 15 years. So these plans locally are under such immense pressure to transform their care to save 22 billion across the country. Now, with little or no funding, and that's the problem. They were promised a lot of funding to be able to transform their services. They don't have much, and a lot of it's going to actually just plug the deficit. So, and a lot of talk has been there's been a lot of talk about moving care away from hospital. So we're in a crisis, we're in a financial crisis. It's cheaper to care for people outside hospitals. Now look, hospitals are not very good at treating people with long-term conditions. The reason is hospital care is episodic, right? You go to hospital for a very short space of time, they fix you, and you get discharged. Problem is, a lot of the conditions that we see now are chronic. They're always with you. And hospitals have not evolved, or the health system has not evolved to look after people with long-term conditions in an efficient way. So the plan is, actually, we're going to have to prevent people from going into hospital and care for them in the community. Lots of problems with this, because it hasn't really been successfully tried, really successfully tried at scale yet in the country. So they're betting on an untried model to save them 22 billion over the next 15 years, and then giving little or no money to help them do this. All right. So not to end on a depressing note. And there are others. So the House of Lords, if you're interested in this, do read the House of Lords report, because I think it's one of the most sensible reports that have come out recently about what we could do about making the NHS more sustainable. So there are sort of potential solutions out there. I just don't think the NHS is being given enough money or time to be able to transform itself. And when the Conservatives, and if we go to the last slide, when the Conservatives, and I listened to them yesterday, talk about the NHS and the fact that they gave the NHS 8 billion. No, actually, that they didn't give the NHS 8 billion. The NHS is due to be in 30 billion deficit. They gave 8 billion. And they're letting the NHS find a way to save 22. And there was a slide I will go back to maybe once or in the question and answers and say, well, actually, 22 billion is if the NHS increases its efficiency by at least 1.5% a year for the next 15 years. So the NHS has to become more efficient by 1.5% every year, and still we're going to be at 22 billion deficit. So if we don't make the efficiencies, then we're going to be in even deeper trouble. So is it just a lack of money? Last slide. Yes and no. It's clear that the NHS is underfunded. I think it's clear from the slides I showed you. But it's not just money. The problem is healthcare is becoming increasingly less and less sustainable. If you looked at that graph of percentage GDP, where's it going to go to, right? In the future, are we going to be able to apportion 20%, 30%, 40% of our GDP on healthcare? I don't think so. The health system has to change. It has to change fundamentally. We, as health professionals, have not come up with anything that is going to transform, or anything proven yet to transform this health service. And that's the big issue. It has to transform, so it's not just about money. The money is going to help. It's going to help us, give us the breathing space to transform, but I don't think it's the be-all and end-all. I think there's going to be some really there needs to be some really hard thinking about the models of care and the way we deliver care in the future. So I think there's going to be a very different NHS in the next sort of decade or so. There's going to be a different type of providers providing your care. So it's not just going to be hospitals. It's going to be people, organisations or providers outside of hospital. They're not necessarily going to be public sector. They might be private sector or voluntary. They're not necessarily going to be delivered by doctors. I think doctors are going to be increasingly, let's just say, there's not enough of them. A lot of their work is going to be taken over by a different class of staff. It could be nurses. I think it's going to be physician assistants that are becoming increasingly popular across the world. And even then, I don't think it's just going to be humans delivering your care. I think technology is advancing so much and the cost pressures are so great that I think a lot of the AI stuff might actually creep in. And there's already an AI, I looked at an AI program that triages. So essentially like, NHS, what's it called? The NHS, is it 111? Where you call up and speak to someone and they offer advice. I've already seen an AI program that can do that through a chat, and it will be able to triage you and tell you what to do without even a human getting involved. It's a bit scary, but we're nearly there. So the NHS is going to have to change regardless. And it might change despite it because of the pressures. The pressures are immense. I don't know how it's going to survive, to be honest, over the next decade or so without at least an influx of money and some, I think, better thinking, to be honest. I think Brexit is going to make things difficult in terms of workforce, but I'm hoping it's going to distract the government enough so that the NHS has got time to reform itself. The 5-year forward view was not a government directive. It actually came from the NHS itself. So I think a lot more of that thinking, better thinking, and more time to think about it might actually happen if the government's, as I said, got to be distracted negotiating Brexit, which is great. But the big but is we've got a snap election now. If we're going to have the Conservatives back in power with a bigger majority, my worry is the NHS is not going to get the funding it needs. Now, they're not stupid. Everyone loves the NHS, as we saw earlier, and I think there's a lot of commitment to the health service. So I don't think they're going to let the NHS fail on their watch. So I'm not sure what's actually going to happen. And I think I'll end there and I'll open it to the floor. So thank you very much.
Thank you very much for very enlightened talk. As you can see, sir, you've attracted a big crowd. My quick question is, with the earlier comments you made, the aging population and chronic illnesses, are you suggesting at some point we stop giving treatment to the elderly, or at how many chronic illnesses do you say, okay, we're not treating you anymore, you go home and die, kind of thing? So
no, definitely not. I'm not suggesting that. All I'm suggesting is I think the population and society need to understand that it's becoming increasingly more expensive, I think, to treat these conditions. And because it's becoming more expensive, there needs to be a conversation about how we fund the NHS more sustainably, to be honest. But yeah, I don't have a real answer to that. But what I do know is end of life is a big issue, and I don't think as a society we deal with death very well. And I think that's maybe something we can focus on, to be honest.
Thank you very much. Another question?
Thank you very much. So one of the solutions you think is to reverse a lot of this fragmentation of the NHS. What practically does that require, and what kind of investment? So to me, it seems like you'd need quite a lot of like shared information services, technology, all of that kind of stuff to then make this type of collaborative working possible. I don't know, shared IT systems, that kind of stuff. That is obviously really expensive. That sounds quite expensive to me, and maybe this is what you're alluding to as well. But then why stop at a kind of particular area? Why not just go back to kind of a big bureaucracy, if that makes sense?
Yeah, so I think there are strengths and weaknesses to having one organisation versus sort of multitude, I think. And I think there's a balance in between. So I'm not advocating going back to one NHS, one big centrally planned NHS, because I think that had its own problems, to be honest. Yes, there needs funding for that sort of infrastructure. The problem is, again, when you fragment organisations, and the problem is they're statutory organisations, so they are answerable to sort of the law in terms of what their scope is and what their remit is. So it's extremely hard to convince organisations that have a very defined scope to work with each other. So, A, you need money to help them work together, I agree, but B, you need to... See, I'm not advocating another reorganisation because that's just going to be another distraction, I think. But we need to find a way to reverse a lot of the legislation in a way that will make them work together. And I think the accountable care model has some promise. So as I was saying earlier, if you force people, if you make them accountable to the same thing, you force them to work together. If their payments are dependent on them working together, so if you incentivize it or disincentivize it in the other way, so penalties if they don't work together, you can sort of encourage collaboration. Still difficult unless you actually merge them back together, but there are ways.
A little bit from my own experience of working with an international NGO that has members and country offices and just trying to get them to work together when they're actually quite separate bodies. So if you think of something like Save the Children UK is very separate to Save the Children US, and that then kind of works through Save the Children International, which is where I work. And to try and kind of harmonize even just across something like that is exceptionally difficult. And everyone is very stuck in their own ways and wants to do things in their particular way because that has implications in terms of how they work within their organization itself. And to try and kind of harmonize, even within, something like that, which is, I think, probably a lot easier than something like the NHS and all of these different types of providers, is very difficult. And they're all accountable to, ultimately, donors. So I don't know, practically speaking, I'm not sure how easy it is to do and to reverse something, and if that makes things worse or better in some senses.
No, I agree with you. I don't think anyone's got a really firm idea of how we're going to do this, to be honest.
Question from the men's side?
Hi. So, just coming back to the previous question. So when the fragmentation happened, for its success, how much do you think that the practitioners within the healthcare system did not actually put in the effort to make it work? So each individual organization within that, right, they did not actually want for that to happen, and therefore this collaborative, talking to other organizations within the whole big system. I think that probably, I know in British society, change is very, very difficult, and people do not want to move forward. So how much of it is sort of, the blame lies with the healthcare professionals?
Okay, I see it in a slightly different way. I think I blame the healthcare professionals for A, not doing enough to resist the actual fragmentation. Their voice, I think, their voice wasn't heard, but I don't think they made that much of an effort. On the whole, I think healthcare professionals have been really bad at managing reform in the NHS. As you said, even if, let's say, for example, the reorganisation wasn't great, but even then, I don't think they... Okay, there's lots of healthcare professionals in the audience. I'm one of them. I'm criticising myself too, but I don't think... I think there's a bit of overwork, but there's also a bit of silo thinking. I don't think as a body, healthcare professionals as a body, speak in a united voice, or B, really know what they want from the health system?
I mean, simple things like, for example, you take a large organization, any large organization. I mean, so when I started in electronic industry, right, at that time we used to have very, very large organizations, right? In the 70s, we had to reform. Because, Japan and other countries were very, so you had to do that. And in a similar way, a large organization, if you were to cut it up into small sections, and each being responsible, but you have to have the coordination between the various different sectors.
Yeah, no, I see what you're saying.
I think, even in our industry, there was a lot of resistance initially, right? But people had to change. That's why if you look at even the manufacturing within UK died down because of the reluctance.
Yeah, no, I see I see your point, and I think it's always been difficult to. I think it's the health sector as a whole has been quite resistant to a lot of improvement and sort of improvements we see in other sectors. But the problem with what the reforms did was it fragmented the NHS, and then it reduced what they called the bureaucrats. Now the problem is the bureaucrats were the ones who actually did the coordination and did a lot of the work that the healthcare professionals wouldn't need to do because they're actually delivering care. So you want your most valued asset to actually deliver your most valued service, which is healthcare. So delivering actual care. When they got rid of that tier of management and then fragmented it. So when you fragment something, you actually need more management because you need to be able to communicate and coordinate across more organizations. So I think the reforms themselves were sort of flawed in their own right. But beyond that, I think a lot of healthcare professionals, again, I don't want to talk, I don't represent them and I don't talk for them, but I think they will say, well, actually, it's a lot easier to reform, let's say, an engineering company. You're producing a product that's not alive.
No. So for example, simple thing like your procurement, right?
Yes.
Like what you're talking about. So perhaps you didn't have people, no experience in procurement.
Yes.
Okay? So therefore, when they're fragmented in terms of, going to different places but if they don't have the expertise in procurement, then they do not know how to negotiate.
Yes, and that's always been an issue with the NHS. It's always been an issue. But again...
So even simple thing like,
But let's say...
Catering, procurement of catering, laundry system or whatever, And similarly then, procurement of any healthcare as well.
Yeah, no, I agree with you. But if you go back, those are the exact expertise that was cut out of the NHS when they did the reform. They cut out essentially a lot of the back office
procurement.
functions.
You were paying whatever you wanted to pay.
No, I agree.
To give, right? So they didn't have the expertise in actually
To
professional procurement.
be honest, they never had the expertise. I agree with you.
Question from the lady side.
Assalamu alaikum. I work within prevention, and I just think that the whole world, and particularly the UK, with our current system, if we don't do something really serious about preventing people getting those chronic diseases, there's just no way out of this. It's always going to be unsustainable, and it's always going to require so much more funding. Eventually, it's just we're not going to be able to afford it. So within that House of Lords report, it said at the end, within the bullet points, protect public health.
Yes.
If you recall it, I'm just interested in knowing what they meant by that.
As usual, public health gets given lip service. Oh, prevention is very important. Oh, yes, it's going to save the day. Even the House of Lords report, and if you read the House of Lords report, because it's quite funny, because they go into detail across all those bullet points, and at the end, they say, yeah, and public health's important, and we haven't had time to really talk about public health, but it's a good thing. Essentially, that's what they say. So read the report, and that's the perennial issue. We're stuck in a cycle where we're treating disease, and we're just not looking at what's preventable. And we don't have time or the resource to look at what's preventable, and so it's this vicious cycle, right? I work in public health here, and I've just moved to local authority, and the public health budget's been slashed by about 20%. And so and this is an ongoing thing, public health is never have the investment required. It's not sustainable without prevention. So, you know, you're speaking to the converted, but just for example, I mean, I don't know if you saw the news report the other day. They did the sugar tax in California and dropped the rate, the amount of sugary drinks being sold by 10%. Okay, and that's a massive number. These are easy interventions. It's not easy because of, again, I said, our economic and sort of social society that we live in. We can't do those sorts of interventions very easily. Unless we can convince policymakers or the government to actually invest in public health and prevention, I think, as you said, it's unsustainable.
I think it doesn't even need a lot of investment in public health. You just need a strong government to come up with
Well, actually, yeah. And again, that's another issue. Prevention takes years, right? And the problem is politicians don't have years. They work in 5-year cycles here, and even less now, right? We need to... So I almost think the ideal situation would be, I'd love it for a government to have a 10-year term minimum, okay? They can then plan. To be honest, I don't mind who's in power, but they need to be 10 years. Because when we try and convince anyone, I'm saying anyone, about prevention, they say, okay, when are we going to see the benefits? We'll see lots of benefits, but it's in like 5, 7, 10, 20 years' time. And they're like, okay, thank you, yeah, maybe someone else will do it. And that's the perennial problem of democracies, to be honest.
Okay,
I'm not advocating
for... Mustafa?
Just saying the obvious.
Yes, Ali, I know it's important to inject more funds. But, you know, public at large don't like paying tax, more tax. And if the funding wants to go higher, we all say that, oh, we don't mind paying tax.
Yeah.
But when you come to that ballot box, when you cross, we put conservative instead of Labour.
Yeah, exactly.
Yeah. Yes, it is.
Well,
No, I don't do that.
It's just a reflex. It's just a reflex.
I don't do that. I don't. So how to change people's perception? Because I don't blame the government, because they need billions of pounds more to put money.
Okay.
well, I think Conservative are taxing people more anyway, so...
Yeah.
What's interesting is the public are actually in favour of funding the NHS more through taxation. Yeah. So, but even putting that aside, that's the problem I've got, is we can't keep increasing the funding of the NHS at such levels. I mean, there has to be a limit to how much we can fund, or how we fund health. The level we fund healthcare at. And I think, again, as I said, it's up to the health system. It's a very expensive system that's not treating the health of the population, to be honest. It's a brilliant system for treating the sort of diseases that we've experienced decades ago. So it's very good at treating, let's say, accidents and injuries, infectious disease, very acute things. Hospitals are really expensive. We need to find a way of actually transforming those into something else that's more sustainable. So general practice takes up 15% of the NHS budget only, 15%, and sees a lot more patients than secondary care. Something like that. And now, my view is you need to optimize primary care. Problem is, I don't think primary care is fit for purpose. If you want to transform and move care into primary care, you can't have independent GP practices. You're going to have to beef them up, get them all salaried, and actually really ramp up the efficiency of primary care. Now, that's probably unpopular, but imagine trying to standardize care across 7,000 different independent businesses. It's not going to happen. It's like manufacturing a car through 7,000 different workshops. You're never going to standardize it. That's my bias against general practice, but it's unsustainable. Whatever model comes along, it needs to break this current model because it's just too expensive, to be honest.
Question from the men's side?
Salam Ali.
Yeah, come on, the doctors. I was waiting for you guys. Come on.
So my first is a comment, and then the second is a question. The first comment is, I believe there's a big change in patient expectation, and that has evolved with time. Patients have become more knowledgeable, the internet, people come to their practice, they come to their specialist, they say, oh, I think I got this, I think I want this test, I think this, that, and the other. And generally speaking, the doctor will say, yes, fine, whatever you do, whatever you want, I will see to your needs. And that has spiraled the cost of everything. In with that, defensive medicine. So people are afraid of being sued, and they are, rather than doing what is in the best interest of the patient, and you talk about being cost effective. The same thing goes with investigations and so on. And doctors are acting in a defensive manner where they look at a patient and they go, do you know what? There's a 99.99% chance you're fine, but that 0.01%, I'll admit you to the hospital, you'll stay in hospital overnight, that'll cost X amount, but practically speaking, the chances of they're needing a hospital bed are remote. So I think that's not a contributing factor.
No, I agree.
The second, and you've almost answered the question I had for you, the system we have at the minute, is it the best system? What would you do? Something you've not actually categorically answered. What would you do or change? Could you go to a semi-private system? Could you go to a subsidized system? Would you semi-privatize it? Would you? What is the best system? Could we implement?
My view is it's not a question of who delivers the care. It's a question of how care is delivered, I think. So, I would definitely ramp up investment in prevention. Obviously, I'm a public health doctor. I would say that. But B, as I said, it's carrying on our investment in secondary care is just not going to get us anywhere, to be honest. We need to find a way. And again, I haven't got the answers, to be fair. Whether you make an insurance system or whether you make it a fully privatized system or you keep it as a very public system, it's not going to solve the problem, I don't think. As I said, you look at the US, where it's got its own issues. That's probably the most fragmented and private system, and you can see how expensive that is. Our European peers have insurance systems that are semi-private, so some private hospitals, some public hospitals, and they work quite well, to be honest. But it goes back, my view is it goes back, but it's still not as equitable as ours. I'm a firm believer in equity of access. So I think our system is amazing at making sure, not turning people away. And I think we should need to retain that whatever we do. I really don't know how to fix this. I know we have to change. I really don't know. It's really, really, really difficult. But as I said, I think care does need to move out of hospitals, to be honest.
We'll have one question from the ladies' side and the last one from the men's side.
Not so much a question as I just felt a bit of shifting onto GPs there. So 2 in 5 GPs wants to quit at present. You get 10 minutes per consultation. Someone comes in, they roll out a piece of paper, and there's just too many problems on there. As you said, you saw 6 problems on average per an 85-year-old. By the time they've come in, sat down, told you what's wrong with them, 5 minutes is gone, then you have to get them undressed and examine them, tell them what you're going to do about it, essentially. So many GPs already want to quit, and you're losing that sense of community and touch and feel and getting to know your patients, and they want to move you into a super hub now. They're talking about super hubs where a good proportion of GPs are going to be in essentially battery hen sort of model of patient care, and that's just so unsatisfying. You don't go into this job not wanting to know at least 1 or 2 things about your patients. You sort of lose all sense of humanity if you do that to your doctor. It's a give and take relationship, and it just seems like a very sad state of affairs if that's what it sort of gets boiled down to. You may as well have the artificial intelligence taking care of you if that's all you're going to have.
Yeah, no, I think that's a big risk, and it's going to happen, I think, to be honest. I think that's what's going to happen. It's just because the sheer numbers and the sheer volume, it's either doctors, and again, I put it back to doctors. I think the doctors really need to think hard and say, actually, how do we think we should care for our patients, and what sacrifices are we going to make? In a sense that I don't think there's ever going to be enough doctors in this current sort of model of care. So I think there needs to be a way of being able to manage more patients, but as I said, in a more dignified way. And part of the solution, I think, is figuring out another type of staff who will act. And again, physician assistants, they're there in the US, they've been established for years, and they're in there in other countries. It hasn't taken off here, but I think something like that's going to have to happen if we don't want the battery sort of hen scenario, to be honest. Primary care is going to have to increase its capacity, and it's going to be a bit like that, unfortunately. Unless, as I said, doctors, again, a lot of these reforms are never clinically led. So it's either it's going to happen to us as doctors, or we try and shape it ourselves. And I don't think, as I said, health professionals from time... It might happen. But you know what? If you're going to... it's still relatively... I think they will vote for your feet, and then we're going to get substituted by another class of professional. I think so. I think that's just going to happen.
Last question from the men's side.
Thanks for the lecture. I just wanted to ask two questions. So one, you've said public health, and we've got to invest in public health. But so I remember reading a statistic that even if we cured cancer tomorrow, there's one pill and we just cured cancer, we're going to extend mortality by 3 years. Okay. Cardiovascular disease, the rates are plummeting. In fact, all chronic disease rates are plummeting. The only thing that's going up is liver disease, right? And that's partly alcohol, well, nearly all alcohol related. And sort of gone are the days where public health professionals are going around, Jon Snow, and saving, stopping cholera epidemics in the community. So really, imagine if we did give public health loads of money, what's going to be the major gain? And the second thing...
You don't want the answer, because the answer is going to be interesting.
Yeah, no, I'm sure we'll see you driving a nicer car. But for the second question, was just on general practice, and just picking up from the following question. So actually, there's this sort of slightly big move into this sort of scientific management, and we've got to just... Each GP can just sort of be there and we can just see one problem. But actually one of the biggest evidences is continuity of care makes the biggest difference to people's health, to people's admissions to the hospitals, all of this sort of stuff. And if you start moving into a slightly more industrial model of general practice and start sort of fragmenting care even further, you're not going to make those savings at all. So even the House of Lords report, it sort of came out that actually the salaried model's got to go forward, but very biased in the people that took evidence from, and in fact actually a lot of the people giving evidence were sort of saying, yeah, we're actually really big sort of factory owner GPs, this is how we make our living, and they didn't really take into account the sort of the smaller independent contractor kind of model, which actually has a fair bit of evidence around its efficacy and use, even though it is hard to reform 7,000 GP practices at once.
Yeah, no, that's fair enough. So the first question, there's a lot of evidence about living healthily, right, and then dying healthily in a sense. So it's not just preventing disease; it's preventing the onset of a lot of these chronic conditions. So it might not extend mortality by that much. Sorry, life expectancy. Sorry, it probably will, but it might not. But actually, it's the quality of your life leading up to your death. That's actually probably more important. What's going to happen then is if you've got if you've got healthier people living longer, what's going to happen? The government's going to put the retirement age up. So sorry, if you invest in public health, you're going to work for longer, unfortunately, to pay for the NHS. And that's probably the realistic scenario, I think. If you live healthily and for longer, we're just going to be working for longer, unfortunately. Unless the robots take over, and then that's fine, right? The other question was... about, yes, I agree. Continuity of care is really important. But as I said, I can't see how, when they're talking about the volume of activity moving to primary care, how the current setup is going to absorb it. That's my issue. And if there's a way of combining that personal sort of relationship with a GP and the sort of scale and quality that we need in sort of primary community care, if there's a way to do that, then I'm all for it. But I don't know or how we can achieve that, to be honest. There's going to be a compromise, and I don't know how big the compromise has to be honest.
Thank you, Ali, very much. Just a quick comment before we finish. Mahfil Ali ladies are, as going on your prevention thing, they started with 1 yoga class a week.